So, you've obviously seen it coming, but I'm going to say dieting is always causal in an eating disorder. You can't develop an eating disorder if you don't diet, right? But it may particularly affect people whose serotonin systems can't compensate for diet-induced reductions of serotonin activity, right? And that might be why you see so many people with comorbid traits like impulsivity and other stuff in the population. And who would those people be? Females, because of estrogen-related links, and their susceptibility to serotonin dysregulation after dieting. Those who have primary serotonergic susceptibilities, such as the low functional allele of the serotonin transporter. Those who have post-traumatic effects. There's a lot of data to suggest also that developmental trauma especially will have lasting impact on serotonin function through adulthood. So that kind of thing. Okay. So it means we got to think now. I would kind of bet you can't answer the question why an eating disorder unless you think in terms of the sociocultural context in which these other vulnerability factors sit. And you'd have to think of contexts favoring thinness. Do you know who this is? Ann Becker? Famous, beautiful study. It was a natural experiment. Ann is a colleague. She's a psychiatrist, anthropologist at Harvard. She was doing her PhD in the early 90s in Fiji. Brilliant, eh? But the brilliant thing was not only that she was on a nice beach, she found a moment prior to the introduction of American television in the island of Fiji. She went in and she measured Fijian women's satisfaction with body image, weight. That's women who are perhaps naturally a little more, costaud, as we would say, than the typical Quebecois variant. These women were fine. They were happy as larks with the way they looked. She went back in, I think it was 1994, I'm forgetting which year. 2 years after the introduction of television, she reported 11% had suddenly started vomiting to control body weight. There was an increase in the presence of eating disorder symptomatology that didn't exist prior. So it's a really nice natural experiment demonstrating that yes, indeed, exposure to media images can have an effect. It's why you might know that, well, okay, I'll leave this for a question period. So, the moral of the story, I guess, would be that if you want to answer the question why an eating disorder, for many people you're thinking generic hereditary vulnerability, perhaps amplified by developmental stress and so on, and then finally triggered by dieting or a social environment that encourages dieting. By the way, I should mention to you that bulimia is the thing that's on the increase in terms of prevalence in societies that encourage dieting. So we have to be very careful about prevention of obesity programs that make people restrict their food intake too much. Okay, last slide, and then I'll sort of, well, let's try, no, actually, I'm lying, it's not my last slide. But just to sort of document that kind of interaction effect, here's a nice study, I think, by Kirsti Ackerman, who works in Estonia. What you have here is people who carry the meta allele or the val allele of the BDNF polymorphism. It's been quite strongly linked to risk of anorexia and bulimia. It has quite direct effects on appetite regulation and things like that. Comparing people who showed a recent history of dieting behavior to those who do not, okay? So I guess if I've explained it clearly enough, are you following in that circled bar there? You're seeing the range of scores on a measure of bulimia symptoms in people who carry the risk allele, the risk gene, who also showed dieting behavior. And over there, you just have a more dramatic measure, a measure of a period of starvation. Okay, so I just want to document that, in fact, eating behavior mediated by genetic effects can predict eating symptoms. So I come back to my initial conclusion, I suppose, and I still have the same conclusion, only now I think it's a little more interesting. Eating disorders represent the activation and shaping by dieting of non-specific vulnerabilities in susceptible individuals. And we shouldn't go searching. Well, I shouldn't say shouldn't, but I don't think we're going to find an eating-specific cause in the form of a gene or some biological system. But maybe we can think of interesting ways in which those systems, which make people vulnerable to other things like depression and substance abuse and so on, interact with environments that encourage dieting. I'm going to skip this for time reasons. I wanted to put in some HPA axis actually because of the chair here, but I'll have to skip it. So I guess I've made the point. You want to answer the question, Why an eating disorder? Personality traits, yeah, they're going to contribute. Being highly dysregulated makes it hard to not go to impulsive acts when you overeat, like vomiting, or being highly compulsive might translate into excessive dieting behavior, but I don't think it's ever going to answer the question. There's no eating disorder-specific personality. Development, again, there's going to be no developmental environment that is clearly conducive to an eating disorder. And in terms of neurobiology and heredity, I don't think we're getting any closer either. But so you're seeing a whole series of non-specific vulnerabilities that get turned on by social pressure. Okay, do I have a couple of minutes? Okay, just to link it a little bit to clinical relevance as well, let's talk about treatment a bit. These are results of a study that we did recently, or a couple of years ago now, I guess, in which we're measuring binge eating episodes in a large sample of bulimic women. Here you have beginning of treatment levels. They're binging somewhere around 3 to 4 times a week on average. After 4 months of treatment in a specialized multimodal treatment, and then after 8 months of treatment, okay? And what you're seeing when I compare the difference between the blue and the red bars is, again, those who are carriers of the high functional alleles of the serotonin transporter and the low functional alleles, okay? So those who might have this proneness towards more dysregulatory pathology, if you like, versus not. I guess you can see the red folks here, who are the ones who carry the vulnerability gene, aren't doing as well in treatment. They're more likely to be binging at the end of the treatment. And in the second graph, they're more likely to be showing anxiety and depression at higher levels midway through treatment. I won't waste. So in terms of the clinical implication, traditionally we viewed eating disorders as some kind of expression of a fundamental self problem that required depth-oriented psychotherapies and very intensive treatments. If we go back to that sort of tripart distinction you see in the population, maybe we can think about it a little differently. There you've got a group of people who have eating behavior problems. Maybe they diet too much and they've dysregulated their appetites and they binge. So they don't show developmental disturbances. They're genetically much more intact. For this group, I would predict that symptom-focused interventions, CBT therapies that really get you to think about why are you so obsessed with being thin and why, and could that be the cause of your bulimia, might be sufficient and helpful. For these folks over here who have much more comorbidity, they're developmentally compromised in many cases, they're genetically more vulnerable, I might say that narrow cognitive behavioral therapy is just kind of inadequate. It fails to respond to the reality of the perpetuating factors in the disorder. So we might want to introduce psychotherapy for impulsivity, mood instability, post-traumatic sequelae where that exists, pharmacological support to bolster up serotonergic sensitivities and that sort of a thing. And so you won't have to accept that as my pure speculation. If you want to read one paper on treatment and treatment outcome and in eating disorders, you have to go to Chris Fairburn's recent, this paper or a couple of others that he's published on the use of a transdiagnostic cognitive therapy. What does their paper report? If you treat high comorbidity eating disorder patients, those who have that profile of multiple symptomatology in addition to eating disturbances, a much more complex multimodal CBT therapy that not only focuses on eating-related cognitions and behaviors, but addresses mood instability and quests for perfectionism and interpersonal disturbances and related things, works better. But I don't know how many therapists there are in the room. I think it's an important lesson for the therapists. If you have a low comorbidity eating disorder patient, a simpler, much less impressive-looking therapy works better. And Chris would say it's because you're not wasting time treating all kinds of things that aren't a problem and keeping the needed focus. So I think it just introduces a little reality to the therapeutic kind of stance that we need to take. But also, I think, says something important about the ways in which genetic information, developmental information, and so on can be really important in dictating, perhaps, what will different people's needs be. So I think I'll dispense with smooth wrap-up and just wrap up right here because I think I'm out of time. Thank you.